Hello, good morning, good afternoon, good evening to everybody joining us today for this incredibly exciting guest speaker talk for HTAi ESHTA, provided by Pascale Lehoux from INESSS, and I'll introduce her properly in just a moment. I'm going to first of all share with you some brief information about the HTAi Environmental Sustainability in HTA Working Group. We now have over 130 members across the 7 perspectives in over 25 countries represented. We have regular guest speakers, including experts in the fields of environmental ethics, planetary health, and pharmaceutical pollution. And we meet every 3 months and more regularly for the work streams. Please access this QR code and the link. I'll share the presentation afterwards to access the Zotero library, which we are creating within ESHTA. This is publicly available. Here is the first publication from ESHTA, the new definition of early HTA and implications for incorporating environmental sustainability. And then we had fantastic publication, the first ESHTA report towards including environmental sustainability in HTA. Sorry, I'm giving you a lot of QR codes here. Apologies. And so this is the structure for ESHTA. We have 3 work streams, and I'd like to please share with you in work stream 1, we have just released the Delphi pre-survey questionnaire, which you can access here to be part of the Delphi study, where we're looking to develop the definition of environmental sustainability in HTA. Thank you. I'm going to stop sharing now. And I would like to really warmly welcome Pascale, who is Scientific Vice President of INESSS and full professor within the Department of Health Management, Evaluation and Policy at the University of Montreal. Pascale has published 2 books and more than 170 peer-reviewed scientific articles. She's received the 30th anniversary medal of the CDAMC and amongst many other accolades. Please may I welcome Pascale. If you have any questions, please pop them into the Q&A and I'll raise them at the end of Pascale's presentation, where she's introducing the framework, which is very exciting for developing environmental sustainability in HTA within INESSS.
Thank you so much, Melissa, for this kind introduction. I will just start sharing my slides. So it's a warm thank you to Melissa. I often think of Melissa as a true dynamo because she's extremely active in the field, and it's extremely satisfying for me to accept participation to this webinar. I would also like to thank Monica Wagner and Bertrand Neveu, who have worked with me on this presentation, where I will talk about the strategy of INESSS for the integration of environmental consideration. And when I prepared my talk, I mostly had in mind HTA leaders and thinkers. So those who might be interested in methodological advances or technical details might be a bit disappointed. So I'd rather be straightforward about this so as to manage expectations. But I do hope that the content of my talk will prompt a stimulating discussion on the evolving role of HTA agencies in addressing environmental impacts in health and social care systems. So my talk is structured around 3 sections. Well, I'll stress the background to the strategy development, so it's the why. Then I will move into the when, the what, and the how. These are the key components of our strategy. In the 3rd section, I will use some examples from INESSS to illustrate the lessons we learned through practice and what remains to be learned in the next couple of years. So for those who are less familiar with INESSS, we are based in Quebec, the largely francophone province of Canada. Our mission is to promote clinical excellence and efficient use of resources in the health and social services sector. And our vision is to produce a tangible impact on collective well-being through knowledge mobilization. We operate according to an integrated set of values that have to do with our core mission, which is based on science. But these values also have to do with our service to the publicly funded healthcare system in Quebec. INESSS employs around 200 employees, and we cover the entire spectrum of health and social care interventions. We have 3 directorates that are assessing drugs and technologies for public reimbursement purposes. We have also a directorate assessing psychosocial services and mental health interventions, and a directorate assessing physical health interventions in a wide range of clinical areas, ranging from primary care to highly specialized care. So what you see on the slide is the planetary boundaries framework that I think is very useful to locate a number of stressors and dynamics that affect globally the resilience of the Earth. So climate change is one of them, and we need to keep an eye on this. So in the 2025 report that is produced by the Potsdam Institute for Climate Impact Research, this report highlighted that 7 of the 9 boundaries had been crossed. So the key message here is that returning to safe operating space is certainly a priority. So keeping in mind that climate change is one among different dynamics that we need to keep an eye on, it might be worth stressing, although some people around the screen may be already highly familiar with those issues, but we need to stress the consequences of climate change on the natural environment on the one hand. So we see increase in global average temperature, extreme weather events, sea level rise, forest fires, air pollution, also a number of changes in the ecosystem that affect the animal and wildlife, but also changes that affect pathogenic factors and allergens. Of course, these consequences translate on population health and well-being. So we do see effects of it on disease, vulnerability, but also on the safety of and effectiveness of drugs and treatments. There are injuries due to extreme weather events, mental and psychosocial health effects, displacement and migration on a global scale, a number of respiratory disease that will be exacerbated by different changes in the ecosystem. Of course, water scarcity, food availability and security that will affect certain populations more directly, and a number of vector-borne and zoonotic disease, either emergence or reemergence of such disease. So there are direct implications for health and social care systems. On the one hand, people are exposed to the effects of climate change, and this will happen on an acute and a chronic basis. So we may project an increased demand for services in the short and longer term. Extreme weather events for decision makers responsible for facilities across regions create some challenges, not only linked to the damages that will be created by these extreme weather events, but also to their capacity to maintain those infrastructures and be prepared. When we look at healthcare professionals and patients, the communities affected, there will be a number of value tensions that can be moral, deontological, and personal. In those events, professionals will have to care for the community, care for their relatives, in the context where access to facilities will be probably highly challenged. So this highlights the need for adaptation. Now, when we think in terms of the contribution of the healthcare sector to greenhouse gas emission, it might be worth stressing that in the Canadian health systems, the carbon footprint that is associated to the healthcare system itself is around 4.6 to 5% in Canada. What you have on the slide are the greenhouse gas emission distribution at the healthcare facility level, the hospital level. So what I like on this slide is that it's showing that around half of the greenhouse gas emissions are associated with care. So we have drugs, we have consumables from the laboratory, we have medical devices, anesthetic gas, and also single-use products. So this highlights the need for mitigation, and it brings us closer to the mission of HTAi. So as Melissa underscored, the inclusion of environmental sustainability in HTAi, but also in the governance of health and social care system, is clearly a topic of growing interest. At the same time, the methods and the operational considerations on how to do this in practice in HTAi remain unclear. And I will turn to a survey by Italian colleagues of 26 HTAi agencies, drawing your attention to specific findings in this survey. The first is that among the 26 HTAi agencies, 69% of them were in favor of incorporating environmental sustainability in HTAi. If you look down the slide, you will see that 35% of them had started to work or were currently working on integrating environmental sustainability. And if we stick to this number of 9 agencies, what you see now on the slide are the barriers that the colleagues have documented. These barriers are rank ordered by level of importance, 10 being very important, 1 not important. So one specific barrier that is of concern to the HTAi community is the availability of data and also the challenges of tracing that data to a specific technology. There is also the lack of scientific consensus on the most appropriate methods to integrate those impacts into our work. So thinking about those results, but also thinking about how the field has evolved recently, one thing that was striking to me is that shall we wait for a scientific consensus or shall we move forward? And for me, the answer was that before a scientific consensus can be made, at least we can develop and implement a strategy. So a strategy is different from a strategic planning activity. What it seeks to do is to make sure that we position an organization in a new space so it can deliver or offer value to its stakeholders that it's not used to deliver. So a strategy makes explicit where an organization aims to go, but also how it intends to get there. So it will include different components, but you need a future-looking goal. So saying, where is it that you want to move with respect to where you are at this moment? And a selected number of objectives and means that will help the organization move. So it's a logical set of hypotheses, but also a limited number of choices, knowing that there's uncertainty that will be discovered along the way. So how did we develop the strategy? Well, of course, we built on the scientific and great literature review. We also benefited from participation to various HTAi communities of practice, and ESHTA is definitely part of them. So we produced a first 10-page document that we submitted through an iterative consultation process. For me, it was important to start with the folks that are more knowledgeable and experts in the field. So we started with experts in environmental sciences, but also the experts from the Quebec National Institute of Public Health. We also consulted a pan-Canadian initiative which is called Cascades, that brings together researchers and clinical leaders. Cascades develop a lot of training and evidence-informed tools to support a transition toward a carbon-neutral healthcare system. We consulted also sustainable development counselors who are staff distributed across the province in different types of healthcare facilities. Green Care clinical leaders in the Quebec chapter of the Canadian Association of Physicians for the Environment. And we also gathered a group of civil servants from the Ministry of Health and Social Services from different clinical areas in order to understand what they were expecting from INESSS, where we could bring a useful contribution. With respect to the literature that inspired our draft strategy, I would stress that we built on the scientific bulletin series that INESSS started to publish in March 2023. So in those bulletins, what you will find is a number of selected scientific papers that focus on three groups or three themes. The first has to do with environmental issues affecting health and social care systems, international initiatives. The second has to do with environmental consideration in HTAi. And the third is a group of clinical studies showing in different types of contexts and care settings, the pathologies and interventions around which research is being produced. So this formed a first basis for us to understand what we could build on. The second document that I believe was shared with you is an horizon scan published by INESSS that looked at 12 agencies that had taken actions around environmental sustainability. So we were inspired by those actions, and they range from position statement to potential methodological approaches, but also patient engagement processes. We also paid attention to the knowledge products that these agencies had produced. And in a nutshell, it was helpful because it helped focus the attention on interventions that are in high-intensity medical specialties, for instance, surgery, cardiology. They focused also on products with high greenhouse gas emissions, if we think of anesthetic agents. They also looked at single-use devices that generate waste. We think in terms of the devices that are used, for instance, by diabetic patients. Energy-intensive technologies such as imaging devices, but also interventions that release chemical agents into the environment. Triclosan would be a good example here. So that type of information help us to define the perspective goal, how we want INESSS to move over the next years. So we were in a state where we had introduced an indicator in our strategic plan and published a few knowledge products, plus the horizon scan and literature review I mentioned. So where we want to go is to move INESSS in a position where it can bring a credible and influential contribution to advancing environmental sustainability within Quebec's health and social care system. So as I said earlier, strategies should rely on a frugal number of objectives. So the first objective for us is to know when to integrate environmental considerations. So it's more the priority setting step. And here the rationale is that from an efficiency perspective, but also based on what we know, it seems highly plausible that for some health interventions, there are efforts to integrate the environmental considerations are more relevant, feasible, but also of greater priority. So to be efficient, we need to know which priority topics we should focus on. The second objective is to know which environmental consideration to integrate. So here the intent is to be as clear as possible when we identify, contextualize, but also communicate those issues, making sure they're understandable, but also actionable for those who use our knowledge products. The third objective has to do with knowing how to integrate environmental consideration and improve over time. So it's the improve over time that matters here. We are facing a situation where methods are being developed, but not yet standardized. The data will not always be available. So what we encourage and promote is to experiment and learn by doing. And this is encouraged, but also supervised. And I'll provide an example later on in my talk. So getting to the first objective, the when, we note that in addition to interventions that are major contributors, either because of their intrinsic environmental impact and or the volume of use, there are interventions that support co-benefits. So these are a reduction in the environmental footprint and spendings and without impacting the quality of care. So a co-benefit perspective is in line with the emerging clinical discourse where good care is green care, but it also allows us to progress in a context where there's not yet a scientific consensus. By that, I mean on the methods and data to be used, but also social consensus on the compromise trade-offs that may be legitimate or less legitimate. So the next slide is a bit busy, but I'll go row by row. It's a preliminary classification of the interventions that could be prioritized. So following a co-benefit approach, intervention that are of low value suggest a number of possible actions for decision makers that include restricting the use in patient groups for whom it doesn't create value. So choosing wisely has produced a number of reports in that area, but there is also literature pointing to many examples. The second row has to do with interventions that do have significant impacts and in situations where there are alternatives with more favorable environmental profiles. So the concept we're trying to capture here is that of equipoise. So facing two interventions, it would be possible to replace one with another option of equivalent value. Studies on dry powder inhalers versus metered dose inhalers are a good example, but there are also more complex care where we could find similar situations such as coronary stenting versus coronary artery bypass graft surgery in certain groups of patients. The third row has to do with interventions that have significant environmental impact and that can be modified to mitigate those impacts without compromising clinical value. So here it's the option is to modify the delivery, the way the intervention is delivered. And here an example could be hypofractionation of radiotherapy in oncology, but also thinking about the various routes of drug administration. The fourth row is to remember that interventions are part of clinical care pathways, some of which may have more environmental impacts than needed. So while improving care, service quality, and efficiency, it's probably possible to mitigate those environmental impacts by optimizing the care pathway. And we see studies coming on showing, for instance, in the case of looking at a pathway for cataract surgery, it's possible to use less material to optimize anesthesia and surgical modalities, but also the energy saving measures. So broader than just the intervention. The last row on this slide is to reverse the perspective and think in terms of interventions that can reduce environmental impacts and deliver value equivalent to current options. So here we see a number of papers around the use of telehealth or digital solutions that operate with or without AI. And the idea is to reduce the travels, be they by patients, clinicians, volunteers. We need to keep in mind that those devices and infrastructures do have an environmental footprint, but it may be possible to look at different options. There is also literature on non-pharmaceutical strategies and social prescribing that would align with this idea of there's underuse of interventions that would have a more favorable environmental profile. So now moving from the when to the what. I believe there are two things that are helpful to keep in mind. The first has to do with the scope. What is the scope of the different impacts we wish to document? And these should cover the life cycle. So imagine a table where in the rows you have different classes of intervention, and in the columns, the life cycle key steps from resource extractions to end of life. So such a table would define what types of impacts to focus on when doing the literature review. The second issue is a little more tricky. It has to do with the level of details that we may wish to bring in an HTAi report. And I'll use an example here of contrast agents that may contain gadolinium that may lead to wastewater residue depending on the capacity of the water treatment installations that have teratogenic effects that will affect certain species and freshwater species, and for which we may ultimately measure an impact on biodiversity. So there's a lot of causal chain component that may or may not be covered. I don't think a single study will cover all of them. So for us, it's really a matter of what type of details we need to bring and what type of information we will find in the literature. So moving to DAO, I think you've already understood that we will at INESSS focus on knowledge synthesis that will remain at the center of our work. The good news is that the literature is getting more abundant, more mature, and it also tends to address more comprehensive measures than greenhouse gas emission. The not so good news about this is that it doesn't not automatically mean that the literature we get is always available for a specific intervention or robust or easy to synthesize. We will observe variations because researchers' choice may vary in a life cycle analysis, what to include, exclude. The data sources vary as well. So our scientists will be facing results that may vary widely, and this will happen between countries, of course, but also between studies from the same country. The other area of development is to focus on tools to assess the quality of these studies, but also their transferability. These need to be tested and validated. So moving to the how, there's another side of the how beyond the methods that is also dear in my heart. It has to do with how we communicate the content we retrieve from the literature. So we know from that literature that that is using specialized terms that may not be easy to understand for readers with different levels of familiarity. So we can make a communication effort to make informative content more understandable, such as translating an amount of CO2 equivalent into a familiar unit, such as a car ride or a transatlantic flight. Another aspect that is important to keep in mind is whether the content we produce is actionable. So here I would say this is content that target elements on which our HTAi users can act on or that are under their responsibility as decision makers. What you have on the screen is a small screen capture of a larger document produced in Normandy. What I like about this screen capture, because the message is clear for a person who prescribes on a daily basis drugs. So give preference to drugs with lowest daily doses of active ingredient. It provides alternatives that can be used, but more importantly, it also conveys the message that a 30% reduction of greenhouse gas emission could be observed. So what I mean is that it seems actionable on a daily basis based on the practice of the clinicians using that type of information. So to summarize what I've said so far around the when, the what, and the how INESSS will be getting there is by building on a number of tools we will develop. So the when, it's a priority setting list of criteria that will be based on a flexible co-benefit logic. Our Bureau of Methods, Data, and Ethics is also active, developing a glossary of key terms and methods in the field. we started producing a series of environmental fact sheets on classes of intervention. So here the goal is for our scientific teams to be able to understand rather quickly what are the key environmental impacts for certain class of information, but also knowing about the literature that has suggested avenues to mitigate those impacts. The how will be addressed through an introductory guide that is adapted to our internal knowledge production processes, but also a series of capacity development and training activities. So this is the when, what, and how of the strategy. What have we learned in practice? What I would like to bring to your attention is, like other HTAi agencies, the first appraisal on which our team went through, I would say, a steep learning curve, was the appraisal of inhaled anesthetic agents in operating room. So here, what is interesting, and it's a unique product in the sense that the goal was to provide recommendations for reducing the carbon footprint without compromising safety, quality of care, and the patient flow. So this was one big piece on which our team developed some expertise. We've also produced other types of knowledge products, clinical guidelines, and here the goal is not to provide recommendations to reduce the carbon footprint, but the goal is to provide information that will raise awareness. So the components in these reports that refer to environmental consideration have not been used to influence the recommendation. So a number of guidelines have been produced. What I will do in the next couple of minutes is to go through an example that will be published soon, and in which it's also a clinical guideline. And the goal for this clinical guideline was to develop the parameters for the appropriate use and safe frequency of imaging tests for monitoring degenerative dilation of the ascending thoracic aorta. So dilation is sometimes confused with aneurysm, but it refers to an increase in aortic diameter, though it's not an aneurysm. It's nonetheless a major risk factor for complication. So the methods employed for the guidelines is similar to what we do usually, triangulation of scientific, contextual, and experiential knowledge. The clinical recommendations are strictly based on patient characteristics. That includes the diameter of the aorta, how fast this diameter, the dilation progress, and other risk factors. So our teams introduced to raise awareness economic environmental co-benefit scenarios, which I will show in the next slide. So what I liked about this is that it provides in this, I would say, a summarized format, an overview that is interesting. So the scenarios were developed for 3 imaging modalities: ultrasound, CT scan, and MRI. A 25-year period is used. The total number of exams that you see on the slide reflect different follow-up calendars that should be based on the patient's clinical profile. So on the left-hand side of the graph, you have the cost per modality. They do include the cost of the procedures as reported by Quebec hospitals and also the fee for services. But those costs exclude the equipment acquisition cost. Looking now on the right-hand side of the slide for the carbon footprint, CO2 equivalents in kilograms were estimated by using data from an Australian study by McAllister and colleagues. And because the energy use may account for up to 90% of the carbon footprint of imaging modalities, our teams extrapolated the energy consumption measured in the Australian study to the hydroelectricity emission factors that are applicable to Quebec. And the energy consumed when the devices are in standby mode are included, as well as the consumables. So, but at the same time, the carbon footprint of patient travels are excluded. So in a nutshell, what the slide shows is that both cost and CO2 equivalent are higher for MRI when it's compared to CT scan and where it's compared to ultrasound. So this type of information is meant to raise awareness, but it also brings our team, I believe, and this is what I like about this example, of the learning by doing process. So the team built experience. We were in contact with them, exchanging with some of their challenges. The feedback we receive from them helps us to adapt our tools to real-world HTAs, and also in the process, test new ideas. From an organizational level perspective, there are other lessons that I've wanted to share with you. So I believe it makes sense to introduce in a strategic plan objectives with respect to our commitment towards environmental sustainability. This is what we did in the 24-28 strategic plan. And it's a target that increases incrementally. So it supports a step-by-step approach, as I showed so far. I believe it helps keep the organization moving in the right direction. At INESSS, we're always looking at those indicators, and we like this idea of improving over time. At the same time, as I said, a strategic plan is not a strategy. A strategy requires a broader commitment in order to bring the organization in a new space, and to deliver an offering that is new, not based on existing routines. So I believe that high-level buy-in is really important to foster a supportive organizational culture. We also need to be realistic in terms of time and efforts in order to mitigate the risk of overload, but also the risk of putting our teams in a difficult position and being uncertain about the methods and data we use. I would like to stress one asset behind that strategy, which is our multi-dimensional value appraisal framework. We spent some time reflecting about how and where environmental consideration would fit into this 5 value domain framework. There is the clinical value domain, the population, the economic, the organizational, and the sociocultural. And we decided to position environmental issues as cross-cutting these 5 value domains. I believe it made a lot of sense because ethical tensions were already positioned as cross-cutting. So I believe it provides some latitude for the team in their reports, but it's also important to keep a holistic or systemic understanding of what is at play with environmental sustainability that has to do with the clinical, organizational, economic, sociocultural, but also the population health level dimension. So I would like to conclude by a few remarks. First, of course, we will be navigating through uncertainty for a couple of years. That requires an organizational ability to learn and improve. I believe collaboration and synergies are really important to consolidate what we do, but also to find the right type of contribution we can make in our close environment. So potential points for discussion, I would be curious about knowing whether other HTA agencies have developed a strategy or clarified the more precise roles they intend to play. What type of priority topics might respond to their own users' informational needs. And before passing the screen to you, Melissa, I will simply do a warm acknowledgement to INESSS team members. A lot of people worked on different reports, brought their brains and hearts to that work, and I'm extremely proud of them. So this is all on my side. I will stop sharing the screen and listen to you, Melissa.
Oh my goodness me, Pascal. I wholeheartedly enjoyed your presentation. It was exceptional. Thank you very much. It's very exciting, heartwarming, inspirational, thought-provoking, thought leadership, etc., etc. So thank you so much. A lot to learn from you. I have written down some of your phrases. Um, the safe space, the adapting tools, learning by doing. I like this is wonderful. Thank you so much. I learn a lot from you, and congratulations to you and your teams. So, we haven't had any questions in the Q&A. Nonetheless, and we have a good length of time left, so please do feel free on those fantastic discussion points that Pascal has shared on that last slide. Feel free to ask or comment in the Q&A. In the meantime, I do have a couple of questions, please, Pascal, if that's okay. Oh, we have something in the Q&A. I'm going to look. Okay, so I'm going to read it out if that's all right. Great presentation. Thank you. You mentioned the learning by doing, which makes a lot of sense to me. Do you evaluate? And if so, how? Process and impact. What a great question.
Thank you so much. We set in place what we call a tactical group. It may sound maybe presumptuous. The tactical group at this moment is comprised of Monica Wagner, Bertrand Neveu, and myself, and that will evolve. So what we try to do is connect while the teams from the scientific directorates are working on a project where they have environmental consideration to look at. So rapid feedback, discussion, and of course, we have this organizational memory, looking at the processes. The goal is to improve, but also understand the challenges they face in real life HTAs. And for me, this was important because, as I said, we need methods and we need consensus. But meanwhile, we need to be clear with respect to how we bring our team in the less secure space, I would say. But they will become more confident and solid by doing this. So I guess processes is the tactical group, and the outcomes we look, because there's a growing number of knowledge products that include those recommendations, and we'll be paying attention to feedback from users of those reports.
Wonderful. Thank you very much. And another phrase I've picked up today, knowledge products. Fantastic. So if I may move on, there's some more, we have more questions. Okay. I might need to wait for my questions. That's absolutely fine. The more the better. Thanks, Pascal. Great presentation. What are your experiences with access to relevant, and in brackets, and local data from WIRE? So thank you.
Hello, Vaya. It's pretty nice to have a question from you. I would like to make a distinction between what we found from narrative review, so what we can describe that other researchers have looked at in terms of the environmental impacts. The data would have to be contextualized, and I believe the data, by that I mean, for instance, the CO2 equivalent or the consumption of energy. And the example I've shown, we used an Australian study. The energy mix in Quebec is highly different, much more hydroelectricity. So we need to do the conversion using an emission factor that is applicable to Quebec, to Quebec hydroelectricity. So we were lucky enough to find a study that had made this work of looking at the energy mix and how it varies. So this is something we discovered by doing. So I would say that I don't have a systematic answer for VEA in terms of the data source, But our team is also looking at a number of the LCA database, some of the tools that look at the care pathways, carbon footprint. So I think a distinction between summarizing what we find in the literature versus extrapolating specific data to the Quebec context.
Wonderful. Thank you very much. Anonymous, thank you very much, Pascale. Fantastic presentation. You touched on great points regarding the scope and hence methodology / depth of analyses. This seems quite balanced, providing the variety of different health technologies to be assessed. What are your views on some systems decisions to clearly prioritize life cycle assessments as the method of choice for sustainability measures? There's a little more, sorry. Should we not all work towards more holistic analyses instead of this single focus on footprints?
I think, Melissa, you could answer that question. But I believe the life cycle analysis perspective is key to understand where the stuff comes from, what type of resources it used, and where it ends up. So a life cycle analysis perspective for me is important. That being said, because there was another, because the question also raised to, does that life cycle analysis focus only on the carbon footprint versus environmental impacts more broadly? And I believe we need to remain flexible. And I would like to identify my dream list of data. But if that dream list of data doesn't happen tomorrow, we need other ways of wrapping our brains around those issues. So life cycle analysis perspective, important to understand what we are dealing with. Carbon footprint, CO2 equivalent are more frequently evaluated, more frequently available.
Indeed, thank you. We have some more questions, so I'm going to keep going if that's all right. From Sylvie Nichols, do you foresee to receive any requests to evaluate specific topics in the coming year? It says topic, but there may be more than one.
It was helpful to meet with civil servants from the Ministry of Health. We are often in contact with them, but this time we brought together people from different areas, oncology, radiology, drugs, and so on. And I believe that the request will be focusing on co-benefits. At this moment, it makes a lot of sense. It's something that can be of value. So I would say, without mentioning specific topics, I believe that anything that can reduce the carbon footprint, maintain quality of care, and reduce spending, make some room in terms of the workforce where they put their efforts will make sense.
Thank you. Anonymous, how does INESSS address data uncertainty and variability when environmental evidence is incomplete or based on secondary life cycle assessment data?
I would love Bertrand to answer that question, but he was told not to, that I will not that I will not put too much pressure. I believe that uncertainty, we look at it carefully. Monica Wagner is also an important person in our group who will look at the literature we quote. So this question needs to be set in the context of clinical guidelines, where we bring environmental consideration as information for raising awareness. So we are extremely careful about the way we position that information. We don't pretend it's complete. We list the limitations. So this is at this moment, our line for dealing with that information.
Thank you very much. There's two more questions. So Sarin, very insightful presentation. Thank you, Pascale. On the which environmental impact to include, I expect the impact profile may vary depending on the technology being assessed? Does INESSS plan on prioritising certain impact categories from the onset when making decisions, for example, CO2, ecosystem, ecotoxicity, etc.?
I would say that at this moment, it may take some while before we bring the environmental considerations into the deliberation. The deliberation for us is the committees who bring harmonize in their views in terms of what will be the recommendations. So at this moment, we don't bring environmental information in those committees. So we don't create an additional tension. So in this sense, I don't feel we need to prioritize the types of impacts we cover because they are more in terms of the goal is to raise awareness, not to bind the committees making the recommendations.
Thank you. Indeed, sorry, please.
It may happen one time, one day. I don't know when.
Yes,
we're not excluding this, and we already deal with ethical tensions. So environmental issues may be part one day of those difficult decisions, but we're not there yet.
Indeed, and why it's sustainable development and there's transitions I can suggest involved in other sectors in this space as well. If I may ask you this last question, please, Pascale, from Fiona Adshead. Wonderful presentation and approach. How are clinicians responding to your guidelines that raise awareness of environmental issues? Are they changing their practice?
That's the key question. How do users respond to the content we share? Some of that content is actionable. Other content may be less actionable. So I believe the answer varies depending on the clinicians you're asking. My impression at this moment, and it's an impression, is that for primary care physicians, there's appetite for thinking in terms of prioritizing what they do, reducing the carbon footprint when it's relevant, and also important for patient experience. In certain specialty care, I can easily understand that specialists in very niched area will not be ready yet to change their practice because of environmental consideration. And I believe this is a legitimate position. Like the guidelines I showed around the aortic dilation, it is expected that to measure progress of dilation, you use the same imaging modality. So it's not a matter of picking and choosing the modality. So yeah, I would say that for certain types of practices, it's more raising awareness and not necessarily having an impact on the behavior, not in the short term.
Thank you, Pascale. And a last comment from Patricia Soares. Excellent presentation. Thank you. Okay, so that was a fantastic Q&A session at the end, and we have 4 minutes left, and I have a feeling that many people on the call will indeed want to get off to their next meeting. I had 2 more questions for you, but I am going to leave that, and perhaps we can follow up afterwards with an email with the questions and share with the people that were participating on the call. So thank you so much again, Pascale, for your excellent contributions to this incredibly important space, and your colleagues too. Thank you again to everybody online and for joining us and for watching back the recording if you are. I'll catch up with you soon, Pascale.
Thank you so much. We will bump into each other.